All right. Hello, everyone. Welcome to another Trainee webinar. I want to be respectful of everyone's time. I know it's a little late on the East Coast. We're going to go ahead and get started. Hopefully, a few more people will trickle in. We're going to cover a lot of information. We're going to tackle some of the most common myths in the PE space and back up the facts with a little bit of evidence. There are quite a few polling options or questions within the Zoom system. We'd love for some audience participation if you can. And then we'll also show those results as well. But before we start, just a quick introduction. My name is Lyndon Lee. I'm finishing my PGY 4 year at UCLA as an interventional radiology resident.
My name is Miriam Shams. I'm a third year internal medicine resident, or just about graduated from Sutter Health internal medicine residency.
Hi, everyone. My name is Sydney Casala, and I am currently finishing up my final year in pharmacy residency, specifically critical care.
Hi, everyone. My name is Shivax Rao. I'm currently a cardiology fellow, finishing up my first year of fellowship.
Hi, everyone. My name is Jane Arrett. I am a PGY 5, soon to be PGY 6 pulmonary and critical care fellow at the University of Vermont.
Hello and welcome, everybody. My name is Ibrahim Zahid. I am going into my PGY 5 of fellowship in pulmonary and critical care at University of Miami, Jackson Health.
All right, we're going to get started with a little bit of a clinical scenario.
Thanks for the introductions, Lyndon, and thank you everyone for joining us today. So we're going to start with the clinical scenario. A 62-year-old man with recent travel history presents with acute dyspnea. Vital signs are stable other than an O2 saturation of 88%. Lab values are pending. An echocardiogram was performed. If you can identify what this echo shows, please drop it in the chat. So here we had an echo with a 4-chamber view showing us McConnell's sign. Our first question is, which of the following statements regarding the echocardiogram finding is most accurate regarding McConnell's sign? Go ahead and vote. The answer choice is C. It may be seen in acute PE, but not pathognomonic, and can occur in other causes of RV dysfunction, which seems to be the most common option. Great. So our first myth that we're going to discuss today is McConnell's sign on echocardiography is pathognomonic for acute PE, which is not true. It is not pathognomonic for acute PE. Next slide, please. So a recent meta-analysis confirmed the McConnell sign, which is defined as RV wall hypokinesis with preserved apical contractility, has a sensitivity of only 22% and a specificity of 97% for the detection of acute PE. In critically ill patients in the clinical setting, patients with acute right ventricular dysfunction, McConnell's sign was found in about 70% of patients with PE and 67% of patients with right ventricular infarctions. Therefore, a statistically non-significant difference and yielding a positive predictive value of only 67%. Other conditions such as right ventricular ischemia or infarction can also produce this identical echocardiographic pattern. McConnell's sign is a useful, rapidly available bedside finding, but must be interpreted alongside clinical context, CT angiography, and other echo parameters. Never treat based on McConnell's sign alone for PE.
Okay, continuing our clinical scenario, we got some laboratory values back that show some mild elevation in our cardiac enzymes. Due to this elevation, as well as the prior echo, a CTPA was performed. So here we have some some axial contrast-enhanced images of the chest. We see something that we see all the time, a filling defect in the main pulmonary artery extending to the bilateral lower lobar arteries. And just from these images alone, it's kind of easy to call this, or to think it's massive or a large tumor burden. We're also seeing evidence of right ventricular strain with an RV to LV ratio of greater than 0.9 as depicted on the image. And so this next question pertains to thrombus burden on CTA. Which of the following statements regarding thrombus burden on CTA is the most accurate? Okay, and the correct answer here is C. Thrombus burden alone has not been shown to have an association with worse outcomes, which seems to be like the majority of the answers. So the myth number 2, quantification of thrombus burden on a CTPA is directly correlated with increased mortality and/or worse outcomes, and thus should be a major factor in risk calculation and management. The truth is, thrombus burden alone on CTPA should not be a major risk factor in risk calculation and management. And just very briefly, I wanted to touch on these because I think they're interesting from a diagnostic radiology standpoint. But here are two scoring systems used for thrombus burden. The one on the left focuses on the location of the clot, with a more midline clot location being a worse severity. And then the table on the right shows a scoring system based off of the diameter of the largest burden in the right and left pulmonary arteries. But studies looking at both of these scoring systems using thousands of patients found no association between increased clot burden and mortality in acute PE. Patients with higher clot burden were more likely to receive ICU admission or use of advanced therapies, likely reflecting perceived severity rather than proven prognostic values. And for these reasons and this research, current evidence does not support incorporating clot burden into standard PE risk stratification models. As we know, clinical status, biomarkers, and RV dysfunction remain more pertinent predictors of outcome.
Shifting gears, our next question is about a different patient that undergoes CTPA and is found to have an incidentally discovered subsegmental pulmonary embolism. Which of the following statements is the most accurate regarding management? Here, the correct answer choice was B. Management of incidental subsegmental PE should be individualized based on factors such as symptoms, DVT evaluation, bleeding risk, and recurrence risk, which seems to have been the most common answer. Great work, everyone. So the myth we're talking about here is all incidentally discovered subsegmental PEs on CT imaging do not require anticoagulation treatment, which is not true. Management of subsegmental PEs should be individualized and some may require anticoagulation. Based on the recent AHA and ACC guidelines, we define Category A PE as incidental and asymptomatic, and some of these Category A subsegmental PEs would benefit from anticoagulation. Based on the recent guidelines, treatment is strongly recommended in patients with a concurrent DVT, active cancer, pregnancy, and persistent major risk factors for clotting.
Alrighty, and taking it back to our very first patient, you have a PERT activation and decision is made to start the patient on anticoagulation. From this information, what agent would you recommend? Alrighty, so we have a pretty split board here. So let's break this down. So bringing us to myth number 4 is unfractionated heparin is faster and safer than low molecular weight heparin for anticoagulation and pulmonary embolism. And this indeed is a myth. Low molecular weight heparin itself actually has more predictable dose response relationship and actually allows patients to have more favorable pharmacokinetics and safety profiles. So as we could see, we were pretty split in the poll itself, and don't think that you're alone. This is actually direct quotes from providers from various institutions that was published, kind of getting their perspective on anticoagulation. And I think one of the most notable here is going to be the very first box. If there is clinical decompensation, the belief that having unfractionated heparin on board is something that you can stop, and that's immediately going to remove the anticoagulation. Also, from the other standpoint, because it's intravenous, that must mean that it works quicker. However, when we take a look at these two agents next to each other, we can see that with unfractionated heparin, it's a continuous infusion. So while the onset of this effect is going to be immediate, that doesn't mean that you are going to reach those therapeutic levels right away. And more specifically, kind of seeing that both of these agents do have a reversal agent if indicated. And you can go ahead to the next slide. This was actually a study to kind of visualize that was conducted looking at patients that were on unfractionated heparin, a continuous infusion. And so we're looking at different time points. And here we can see that at 6 hours, only about 15% of patients ever had a level, specifically APTT, that was in therapeutic range. And then furthermore, once we go to 24 hours, we see that only 50% of patients ever had a therapeutic APTT. So we know anticoagulation is the cornerstone of treatment. And for a patient to go an extra 24 hours, 1 and 2, without actually being anticoagulated does raise the question as to whether heparin is the best agent. And furthermore, because there's been several studies investigating this, we had a Cochrane review that looked and assessed overall based on the evidence that was published. How do these compare? And not only did we see that low molecular weight heparin was actually associated with a lower recurrence of VTE, it also was associated with a lower hemorrhagic risk, which maybe is something that might catch a lot of people off guard. So when this agent is able to be used, it is our preferred.
And we also have a quick companion case for Sydney's last question. Which of the following statements regarding anticoagulation prior to catheter-based therapy for acute PE is most accurate? Okay, and the correct answer is B. Therapeutic AC such as low molecular weight heparin has been shown to be safe to initiate before and continue during catheter-based PE intervention. Which looks like the majority of you had answered. So the myth here, therapeutic anticoagulation such as low molecular weight heparin must be reversed or held prior to catheter-based therapy. The truth is, continuation of therapeutic AC during catheter-based therapy has not been shown to lead to increased bleeding events. And this is a very common thought. We did a survey at our last PERT annual meeting, the Trainee Council did, and it showed that up to 35% of providers discontinued anticoagulation before catheter-based intervention. Studies show, however, that no statistically significant increase, or that we saw no statistically significant increase in bleeding events when patients were maintained on therapeutic anticoagulation, and this was tested both in unfractionated heparin and low molecular weight heparin. So these findings support initiation and continuation of anticoagulation from diagnosis through interventional management in appropriately selected patients. And this is important because timely and therapeutic anticoagulation is the cornerstone of PE therapy, and this will help prevent further escalation of severity as well as recurrence of VTE.
And then as we transition through our anticoagulation myths, we transition to our direct oral anticoagulates. And common perception is that they are all equally safe and effective for the treatment of venous thromboembolism. And while each of these agents has proven to be efficacious by getting their FDA approval, they are not all equal in terms of their safety profile. And more recently, we actually finally had a direct head-to-head trial. And this is the first randomized control trial directly comparing apixaban versus rivaroxaban, the two most popular oral anticoagulants on the market. And what this trial discovered was when looking from a safety standpoint of clinically relevant bleeding, at 3 months, we saw a notably significant lower risk and incidence with apixaban when compared to rivaroxaban. And actually looking at this, furthermore, you can break it down and see that this is about a 50% risk reduction. That is something that can be very significant to our patients, and especially those in which the bleed risk is something that is of higher importance. Now, with this study being published, the question becomes, why wouldn't you choose apixaban naturally? And so those are going to be in instances when we still don't have the evidence to support use of our DOACs in certain patient populations, like those with a mechanical heart valve, if they have a left ventricular assist device, antiphospholipid syndrome, as well as pregnancy and breastfeeding. But some others to bring to your attention are going to be patients of extremes of obesity. There is data to suggest we can kind of push the boundaries on their BMI, but we really do not have evidence in patients that are BMI greater than 60. So from that standpoint, something that we can actually monitor by therapeutic drug monitoring would be a potentially preferred option. And then something to take into consideration as well is going to be social factors. So patients' access to medication as well as adherence concerns, with primarily the biggest difference between those two agents in terms of patient administration is going to be something once daily versus twice. And taking all of what we've reviewed on anticoagulation in the setting of pulmonary embolism with our new guidelines, this is an illustration that really shows how each of these agents has a role when it comes to classifying the category of PE. And so it'd be interesting to see how these develop further down the line of our newer trials that have come out. However, noticing that low molecular weight heparin is the preferred agent in our category C and D, with the exception of E being something where you could consider unfractionated heparin.
Now, switching gears to the interventional side, looking at starting off with a case presentation here. So there's a patient with an acute pulmonary embolism who has a contraindication to therapeutic anticoagulation. Which of the following statements regarding IVC filter placement is false? Take some time and go ahead and vote. The correct answer here is option A. IVC filter placement in PE patients who cannot be anticoagulated reduces mortality and prevents recurrent PE. And a quick look at the poll results. So it looks like we had quite a bit of a split between the first three options here. So we'll take a look at some of the evidence behind this. And to clarify, this particular myth itself is indeed incorrect. And IVC filter placement in PE patients who cannot be anticoagulated indeed does not reduce mortality and does not prevent recurrent pulmonary embolism. So we'll take a look at the evidence behind this. And there's two relevant prospective RCTs that have been previously done, PRAPIC 1 and PRAPIC 2 trials. They investigated IVC filters in patients with acute venous thromboembolism. And the first study showed that there was a lower rate of symptomatic PE with permanent filters, but that was actually offset by a significantly higher rate of recurrent DVT between the two groups. And essentially, there was no significant difference in mortality between the groups either. Then we look at the PRAPIC 2 trial that enrolled about 399 patients that had acute symptomatic PE and DVT, adding a retrievable filter to anticoagulation versus just going with anticoagulation alone. And the results of this study showed that at 3 months and at 6 months, the rates of recurrent VTE were low and they were not significantly different between either group, but there tended to be there was a higher tendency towards a higher PE recurrence and higher mortality in the group that received the IVC filter, in addition to the anticoagulation. So overall, the only universally accepted indication that we have for IVC filter placement based on the AHA guidelines, it's a class 1 level B recommendation, is for patients that have acute proximal DVT or PE and an absolute contraindication to anticoagulation or a proven failure of anticoagulation. Moving on to myth 8, as we look at other interventional therapies for VTE, catheter-directed therapies for intermediate risk PE only improves surrogate endpoints like RV-LV ratio, but they don't improve or reduce clinically meaningful outcomes. This indeed is a myth because we do have recent studies in catheter-directed therapies for intermediate risk PE patients that have directly evaluated primary endpoints and clinical outcomes, including mortality. So there are three big studies, and this initial belief that led to this myth that I just highlighted was supported by the fact that old trials of catheter-directed therapies like Ultima, Seattle 2, FLAIR, and Extract PE, they primarily relied on surrogate endpoints like RV-LV ratio reduction rather than using clinical outcomes. But we do have newer studies. We have the Peerless study from 2025. We have the Storm PE trial from 2025, as well as the HiPytho trial released in 2026. And all three of these studies show us that clinically meaningful endpoints, in fact, are improved with catheter-directed therapies. So we'll take a look at each of these. So the Peerless trial from 2025, major randomized controlled trial enrolling 550 intermediate risk PE patients, and they were randomized to either large bore mechanical thrombectomy versus catheter-directed lysis. And this trial essentially, while it compared these two interventional strategies rather than just a single intervention to anticoagulation, it did demonstrate that large bore mechanical thrombectomy had lower rates of clinical deterioration between the two and less ICU utilization, with really no difference in the mortality or major bleeding between the two approaches. So they looked at things like the dyspnea score at 24-hour visit and also RV function at 24-hour visit. But it's also important to note, as we see on the next slide, that the study looked at additionally clinically meaningful endpoints as well. So they looked at post-procedure ICU utilization, post-procedure ICU length of stay, total hospital length of stay, and post-procedure hospital length of stay as well. And here we see statistically significant differences between the two groups when it comes to these endpoints. Next, I wanted to head into the STORM PE trial, which was also published in 2025. It was an international open-label, one-to-one randomized trial recruiting patients across 22 sites. And it essentially compared aspiration-based computer-assisted vacuum thrombectomy using the Penumbra system versus plus anticoagulation versus just anticoagulation alone. And it demonstrated superiority with the computer-assisted vacuum thrombectomy plus anticoagulation group in endpoints such as RV-LV ratio reduction at 48 hours, but also at pulmonary artery obstruction scores, and also early normalization of vital signs within patients in that arm as compared to the anticoagulation alone arm. It was the first randomized controlled trial with randomized anticoagulation alone arm for mechanical thrombectomy. As we saw, Peerless did not have such comparison. And also, it included a composite clinical safety endpoint of major adverse events at 7 days. So the design papers specified a 90-day functional and quality of life outcomes as well, in addition to the surrogate endpoints. So these were all patient-centered endpoints. But longer term results have not yet been reported from the primary STORM PE publication. And lastly, I'd like to take a brief look at the HI-PEITHO trial, which was recently published this year. This was a landmark multinational RCT of 544 patients with intermediate risk PE. They randomized patients to the ultrasound-facilitated catheter-directed fibrinolysis plus anticoagulation arm using the ECOS plus catheter from Boston Scientific compared to the anticoagulation alone. And the primary composite endpoint that they looked at, it was a composite outcome of PE-related death, cardiorespiratory decompensation collapse, or symptomatic PE recurrence within 7 days. And when you look at the breakdown, a lot of it came from differences in cardiorespiratory decompensation and collapse. But overall, the primary composite endpoint occurred in 4% of the catheter-directed lysis group versus 10.3% of the anticoagulation alone group. There was no significant difference in major bleeding, and no intracranial hemorrhage occurred in either group. And in the ensuing slides, we highlight those differences in tables. Here, looking at the primary composite endpoint, and you'll see in the breakdown that it was primarily driven by differences in cardiorespiratory decompensation or collapse being greater in the control arm as compared to the intervention arm. And then on the next slide, we're looking at major bleeding outcomes that were statistically non-significant between both arms. And lastly, we're going to look at intracranial bleeding and death from any cause and outcomes at 30 days, serious adverse events through 30 days, which were also statistically insignificant between the two arms.
All right, so stepping into the ICU, starting with a case. So we have a 68-year-old man admitted to the ICU 8 days ago with acute cholangitis, complicated by septic shock and ARDS, requiring intubation on hospital day 2. He has remained mechanically ventilated for 6 days, and he currently is on volume control with a tidal volume of 420, a respiratory rate of 18, an FiO2 of 35%, and a PEEP of 8. There's no circuit leak. Over the course of 2 hours, he developed sudden cardiopulmonary deterioration despite no changes in his vent settings. So you notice that his heart rate goes from 78 to 112. His blood pressure starts dropping from the 120s over 60s to 90s over 60s. He becomes more hypoxic, at first satting 95% on 30% FiO2, and now satting 87%, even with an oxygen saturation, even with an FiO2 of 60%. And his end tidal drops from 36 to 19 millimeters of mercury. There's no change in his peak or plateau pressures. And he has an ABG demonstrating a pH of 7.32, a PaCO2 of 52, and a PaO2 of 58. So the question is, you can read those answer choices. All right, so we've got a little bit of a mix here. So The correct answer is C, a sudden decrease in the end tidal CO2 with widening of the PA CO2 to end tidal gradient, despite unchanged airway pressures. So I'm going to go over why that answer is correct and why answer choice B is incorrect. So the myth here is that standard diagnostic tools can reliably identify PE in critically ill, mechanically ventilated ICU patients. Whereas in reality, the clinical prediction tools that we use in everyday life were validated in ambulatory populations or patients who were not critically ill and ventilated. So they are not applicable to ICU patients. In fact, PE is notoriously difficult to diagnose in mechanically ventilated patients. So the reason that answer choice C is correct has to do with dead space physiology and ventilation perfusion mismatch. So a PE is a vascular occlusion that results in not only a mechanical obstruction, but also the resultant hypoxic vasoconstriction. This causes the downstream units of the lung to become ventilated but not perfused, and this creates an alveolar and thus a physiological dead space. And so there's something called the PaCO2 to end tidal CO2 gradient, which is kind of a poor man's test to estimate an alveolar dead space, but it's quite useful, and we use end tidal CO2 all the time in the ICU. So the end tidal CO2 is the partial pressure of CO2 in the gas at the end of exhalation, where it most closely resembles the alveolar CO2 concentration. With that being said, this is when it closely resembles the alveolar CO2 in healthy lungs. So this patient that we're talking about with ARDS does not have healthy lungs. And so we can't use the absolute number per se. However, we can look at the trend. And looking at a sudden drop with unchanged airway pressures tells you that there is something causing a mismatch between ventilation and perfusion that is not having to do with an airway obstruction. So going to the next slide. So I want to just touch on the mechanisms of hypoxemia in PE. Going back to the 1985 inert gas study, we know that the most common cause of hypoxemia in acute PE is a VQ mismatch. However, there are some other causes of hypoxemia in PE. So you can, when there's a hemodynamically significant change in a PE patient, they can get decreased cardiac output, which can result in a low mixed venous oxygen saturation. This is another cause of hypoxemia. But the reason I show this slide is because I want you to think about going into the next question, that profound hypoxemia in a PE patient often indicates that there's some sort of shunt going on, and it doesn't correct completely with oxygen. So an intrapulmonary shunt is quite infrequent, and it often tells you that there's something else parenchymal going on, such as a pulmonary infarct, maybe some atelectasis, maybe some pneumonia. But the thing that is truly dangerous in these patients is when there is a PFO. So PFO causes a right to left shunt in patients with PE. And there's been a couple of studies on this, retrospective, albeit, but about 30% of patients with acute PE have a PFO that opens up when the right atrial pressures exceed those of the left atrial pressures. And so these patients will not improve with supplemental oxygen, and mechanical ventilation can actually make these patients worse. And I want to just backtrack a moment, going back to what happens when you're mechanically ventilated, because a lot of people in the audience chose option choice B as the correct answer. So RV dilation, septal flattening, and lack of respiratory variation with your IVC is often found in PE patients. And, it's often a sign of right heart strain. However, positive pressure ventilation and PEEP increases the transpulmonary pressures, the intrathoracic pressures, which actually compresses the extra alveolar vessels and increases your pulmonary vascular resistance. So patients who are mechanically ventilated have an increased RV afterload and RV dilation. Adding on to this patient who had ARDS, they have another reason to have RV dilation as well. So when the RV dilates, the septum starts bowing into the left ventricle, and this causes the septum to shift. Another portion of option B was talking about the IVC. So positive pressure variation causes the IVC dimensions to increase in both inspiration and expiration, and thus the collapsibility index decreases. So while bedside focus is one of the most important tools we have in the ICU, seeing RV dilation and some septal shifting doesn't necessarily mean that there's a PE. However, when you notice that there's a sudden drop in that CO2 gradient without any changes in your airway pressures, that's when you want to start thinking, okay, does this patient have a PE? So another thing that I wanted to mention about these patients is that in the ICU, a D-dimer is, to be quite frank, kind of useless because it's a marker of inflammation, it's a marker of acute illness, and so we can't really rely on that either. So for the next question, I want you to keep in mind the mechanisms of hypoxemia and PE, and keeping in mind, which types of hypoxemia would respond well to supplemental oxygen. So our next clinical scenario has to do with a 55-year-old man who presents with an acute bilateral PE and RV dysfunction on echocardiography. His heart rate is 114, his blood pressure is 94 over 58, his oxygen saturation is 84% on a 15 liters non-rebreather mask. He's alert, protecting his airway and speaking in full sentences. The respiratory therapist asks you what size tube you want for intubation. So the question is, which of the following is the most appropriate next step? All right, so the correct answer is B. Switch to high flow nasal cannula and add inhaled epoprostenol. A couple of people did choose option A for rapid sequence intubation. And a couple people did choose option D, administering 100% FiO2 while you prepare for intubation. So I know that these answer choices were long, but I have a couple of points to illustrate with them. So the myth here is that the hypoxemic PE patient should be intubated before they decompensate further, which is false. So intubation in acute PE is a physiological, difficult airway and should be avoided if possible, as it can precipitate cardiac arrest even in hemodynamically stable patients. So a lot of what we know about this cardiovascular collapse is it's coming from the case series of surgical embolectomies, whereby up to 30 to 40% of patients have a cardiac arrest following induction of anesthesia and intubation in the OR when going for a surgical embolectomy. And some studies even show that up to 50% will have hemodynamic instability within the first hour to 3 hours of induction and intubation itself. So the 2026 AHA-ACC guidelines actually say anesthesia induction and mechanical ventilation should be avoided whenever possible, and that we should exhaust all non-invasive options first. In particular, high flow, non-invasive ventilation, such as BiPAP, with a caveat there, and supplemental oxygen, even without hypoxemia, because oxygen it acts as a pulmonary vasodilator, reducing RV afterload. So before I go on to the next slide, I just want to make note to the audience that we do have a question and answer section here. So type your questions in and we can answer them as we continue to move along forward. So Lyndon, would you mind proceeding to the next slide, please? So many of us are familiar with the RV death spiral. So this RV death spiral is basically all about physiology and all about why patients with PE can crash after induction and intubation. So rapid sequence intubation and invasive mechanical ventilation exacerbate the physiological derailments of obstructive shock. So acute PE, because it's resulting in this abrupt increase in pulmonary vascular resistance and RV afterload through the direct physical obstruction and the hypoxic vasoconstriction, acute increases in RV afterload worsens, the RV output, worsens myocardial ischemia, and thus results in ventricular interdependence to result in systemic hypotension and eventual cardiovascular collapse. So rapid sequence intubation, even with the most cardiostable agents you can use, it will cause a reduction in the preload, and mechanical ventilation will cause an increase in the afterload. The process of using rapid sequence intubation also entails the use of a paralytic oftentimes. And so that leaves us with apneic ventilation, which can increase hypercapnia, worsen hypoxemia, and all of that worsens the pulmonary vascular resistance and can contribute to this RV death spiral. And then, as I touched on earlier, positive pressure ventilation increases the intrathoracic pressure, resulting in increased RV afterload, decreased RV preload, and a drop in your systolic blood pressure. So intubating a PE patient is the last thing that you want to do. You can go on to the next slide. But if you absolutely have to intubate them, you need to approach it as a physiological difficult airway, and here are some tips for you. So it's always a good idea to have a pre-induction arterial line if time permits. Sometimes it doesn't, but if you can get an A line in quickly, do it early and do it quickly. Having adequate access is a given in the ICU. A couple of peripheral 18 gauges is, okay, but if you can get central venous access, that's preferred. Cardiostable induction, if you're going to use rapid sequence intubation, that study that came out looking at a comparison between etomidate and ketamine back in, I think it came out in December of 2025, showed that etomidate actually had fewer hemodynamic consequences. So etomidate or ketamine can be used, but ketamine with the caveat being that sometimes it can increase your myocardial oxygen demand. But those would be the two. You want to avoid things like propofol, who are going to worsen the hemodynamics by completely wiping out your compensatory mechanisms. Vasopressors, I usually like to have Levophed infusing with epi, pushes of epi on standby, and an infusion of epi ready to go as well. Consider inhaled pulmonary vasodilators such as epoprostenol or nitric oxide. If you're pre-oxygenating with BiPAP, you can actually infuse them through the BiPAP circuit, or if you're pre-oxygenating with high flow, you can infuse them through the high flow circuit as well. With the caveat being that at high flow rates, we're not quite sure how much of the medication will actually be delivered to the lung tissue, but have those if you have them available at your facility. Other things that you want to think about are, correcting for any acidosis that the patient may have that's going to worsen your pulmonary vascular resistance. So if it's a metabolic process, you can give an amp of bicarb, depending on the clinical scenario. Upright positioning is super important in any physiological difficult airway, and this has to do with your lung mechanics. So there's been numerous anesthesia studies looking at the effect of positioning on functional residual capacity and lung mechanics. So when you put the patient in supine positioning, the functional residual capacity can drop up to 25% in non-obese patients, and even more so in patients who are obese or who are pregnant or who have any other type of process going on that, is causing increased intra-abdominal pressure. So if you can have the patient in the upright positioning, ideally the 30 to 45 degree range, that would be ideal, and that can help preserve the FRC, prevent hypoxemia, and prevent worsening hypercapnia. If you're at a facility that has ECMO, make sure that you have it on standby and even consider awake cannulation. It's also a good idea to have cardiac anesthesia aware, but if you're working in the ICU and you don't have them, you got to know how to do it yourself. So pre-oxygenation is something that, we know improves outcomes in any patient before getting intubated. So you want to make sure you're not skipping that step. And then lastly, if you're comfortable with it, consider an awake bronchoscopic intubation, which can use minimal, sedation medications such as small doses of Versed or fentanyl and topical lidocaine. However, I will say that the best way to intubate a high-risk intubation is to use the method that you're most comfortable with. You can go to the next slide. And so I just wanted to briefly touch on the bronchoscopic intubation for physiological difficult airway. The photos on the right came from May West, who is one of our mentors here at the Trainee Council. So thank you for that, May. This is just showing what the bronchoscopic intubation would look like. And many people in the ICU are comfortable using a bronchoscope to, facilitate intubation. But if this is not something that you're comfortable with for a physiological difficult airway, don't make this your first one. So, and this is just another graph showing from an anesthesia journal the decline in FRC from the standing to the supine positioning. You can see that graph on the right there showing a drastic drop in the FRC in liters when you're moving from the standing to the supine position. And last point on the bronchoscopic intubation is that technically the patient is awake. You're avoiding the use of paralytics. You're minimizing your apnea time, which is going to overall help avoid a potentially catastrophic collapse when you get the airway in this patient. Okay.
Wow, I've learned so much from my colleagues here. Just moving on to the next segment. This is actually the last segment of the evening. And here's our clinical scenario. A 58-year-old woman with a history of pulmonary embolism on Eliquis presents with progressive exertional dyspnea and fatigue for the past year. An echo demonstrates right ventricular enlargement and a high RVSP of 65, and CT pulmonary angiogram is reported to show no evidence of acute or chronic pulmonary embolism. Despite this result, her pulmonologist remains concerned about CTEPH. Let's look at the question. So last question of the evening, which of the following is the most appropriate next step? I'll let you guys pick this one up. I'm expecting no less than 100% on this one since you've already learned everything. We're just shifting gears to CTEPH now. Going to talk a little bit about that today. And I think if you guys are all done, we can look at the answer now. All right. Perfect. I mean, pretty good. Solid there. Obtain a VQ scan to evaluate for chronic thromboembolic disease. Most of the people got this answer correct. And let's look at the myth then. So this is what I also used to believe, like, as a resident, like a normal CTPA rules out CTEPH. But no, that's not true. A normal CTPA does not rule out CTEPH, and they should definitely be further evaluated if you are really concerned about a patient having CTEPH. So, let's look at the next slide. So you are trying to diagnose, you have a patient who has dyspnea, a patient who does or doesn't have a history of PE. Well, let's say they have a history of PE, and now you're concerned about dyspnea after like 3-4 months. Uh, there are a couple of reasons why they can have that, but what your most top differential, what you should be thinking at the time, would be if the patient has CTEPH or pulmonary hypertension secondary to the PE that they had. Echocardiogram is a very good tool in screening for pulmonary hypertension, like what we saw in this case, where we had a high RVSP, right ventricular dilation. That would indicate if a patient had PE or didn't really have a history of PE, you would start to think, oh, why would they have a high RVSP and RV dilation? Now, European Association of Nuclear Medicine and European guidelines from 2009 on the diagnosis of and treatment of PH recommend that any patient with unexplained PH on an echocardiogram, especially with the patient who has a history of PE and DVT, should undergo a VQ scan for CTEPH. And I'll tell you what the reason is. So if you go into the next slide, Lyndon, VQ scan is actually more sensitive than a CTA to rule out a PE or a CTEPH. It's it's shown to be 90 to 100% sensitive, and if you are doing a CTA, it can potentially miss a subsegmental disease. What you would do in terms of diagnosing a patient with CTEPH is you can start off with an echo to screen for PH. Then you would go on, if you're thinking about CTEPH as a possible cause, then you can go on to do a VQ scan. Now, since we have a very sensitive scan with almost like 100% sensitivity, it's a very good rule out. So if they don't show any perfusion defects on a VQ scan, it's easy to rule it out. You've ruled out CTEPH. However, if it is positive, then you go on to CTA if you haven't already obtained it, and then you can easily locate the anatomical extent of that clot to help you in surgical planning, which is endarterectomy. Now, once that's done, especially if you're considering a surgery, or even if you're not in some cases, a digital subtraction angiography, which is an invasive test, remains the gold standard to reach the final diagnosis and help with procedural planning, like I said. A right heart cath with conventional pulmonary angiography was also like commonly used before DSA was prevalent in our practice to diagnose CTEPH. However, even if you are doing a right heart cath, it's important in diagnosing, yes, it's a precapillary pulmonary hypertension, which could be due to CTEPH, and also you can measure pulmonary artery occlusion pressure to make sure that it's not a postcapillary hypertension, which may be contributing to your pulmonary hypertension. So that's how you diagnose a diagnose CTEPH, and that's the diagnosis steps. And it's also highlighted in the 2026 AHA guidelines. Let's go on to the next slide. I am a man of pictures, so I did put up a picture of a VQ scan here, showing a perfusion defect where you would be, after this, like I said, 100% sensitivity, you would be highly concerned about a pulmonary embolism. And also there is a picture of a volume rendered CTA and an MR pulmonary angiography. I'm not sure if you can see my cursor here, but here the arrows in the pictures point towards the attenuated pulmonary vasculature, which indicates towards the final diagnosis of a PE causing CTEPH. That is all from my end on the CTEPH and diagnosing it with VQ scan. These are all our references, and I hope you guys had a good time and learned a lot from this webinar. I myself am one to learn a lot from this and from all of my colleagues. We have this slide to indicate that we have our per annual meeting from October 1st to 3rd this year, and we're very excited about that. And it is preceded by Fellows Boot Camp on 30th September, which I highly recommend to attend. I've been on both sides of the boot camp, attending it, and also had the honor of presenting at it. So I highly recommend it to all of our trainees who are here in our webinar. And this QR code would direct you to the website, which would also help you in registering for the meeting. Over to you, Lyndon, if you have any final words.
Yeah, I just wanted to, we have a few minutes left. If any audience members have any questions, feel free to drop it into the Q&A chat box. Yeah, thank you everyone for coming. We kind of wanted to hit the key points or the key myths from key points in the care of PE from diagnosis to, post-PE care because it is so common and so relevant. We'll also take questions about the trainee council, if there's anything in general that anyone is wondering, as well as the boot camp, as Ibrahim had said.
I would just second what Ibrahim said about the boot camp. The boot camp is a great experience. I think I've gone 3 times now. And it is so much fun. You learn so much, and you're learning from the top people in this field from different specialties. It is a once in, a career opportunity for you to go enjoy it, and get as much out of it as you can. And the meeting is, such a great time, so many great minds in one place. So I definitely just want to second what Abraham and Lyndon said about the boot camp and the meeting, and really hope to see you all there.
I think we did get one question in the chat, and just to answer verbally as well. Someone was asking if the recording was going to be, or if the webinar was going to be recorded. It won't be sent out, but they will be on the PERT website, as are all the past webinars, which are, very, very helpful as well.
So it looks like we did get a question in here from Anoop. It says, if IVC filter does not reduce mortality or PE, then why put one in?
So Shiviax, do you want to answer that question verbally so we can?
Yeah, absolutely. I can take that. Oh, I think is Dr. Whitkin going to be in? It says she's attempting to answer this question live, is what I'm seeing in the chat. I'll go ahead and give this a shot. So essentially, we do have we have data that essentially is supporting that in patients that have absolute contraindications to anticoagulation, we looked at 2 trials. We looked at PRAPIC 1, PRAPIC 2, and essentially they showed lower rates of symptomatic PE in patients with these filters. There was a higher rate of DVT, but at the outset, it is something that we can do for patients that absolutely have an absolute contraindication or failure of anticoagulation. So we need to select our patients carefully about who we're putting it in, is the bottom line. The other thing is a lot of these newer filters are retrievable, and maybe Lyndon can touch on this with any experience from radiology residency. A lot of these filters tend to be retrievable nowadays, and it's important to not leave them in over time, over the long period of time as well, since they are foreign bodies and thrombogenic foci lying in the veins. So overall, the message is it's not that we shouldn't put them in, it's that the patient selection should be very careful, and the patient should be selected very well in terms of who's a good candidate by following the universal guidelines, which at this point just say the ones that have either absolute contraindications to therapeutic anticoagulation or have failed therapeutic anticoagulation or anticoagulation.
Have kind of a follow-up question to that, I guess. Would there be any concern for, some of the indications of anticoagulation are going to be your patients that are severely thrombocytopenic, maybe have some type of ongoing bleeding? Does that kind of preclude patients from also being candidates for IVC?
Sorry, so Sydney, you said thrombocytopenic patients that are prone to bleeding.
I think what a question being like from the end of, you have a patient that you are assessing if they can have an IVC filter placed in. Would there be any instances where maybe the reason that precludes them from being anticoagulated would also preclude you from performing like the actual procedure itself?
Yeah, that's a good question. I think that's an interesting question. That's an interesting point you mentioned about procedural risk of bleeding as well, associated with something like severe thrombocytopenia, for example. I would probably say that in that case, there is a risk-benefit discussion to have with the patient in to the effect of saying that, there is a high risk of bleeding with therapeutic anticoagulation, which is why we would not be a good candidate for that treatment modality. But there's also a peri-procedural bleeding risk with the IVC filter placement in general, though that might be outweighed by the benefits of the IVC filter reducing further PE. I think we see that not just with IVC filters, but a lot of procedures in general, right? Whether it might be a stent in a peripheral artery or coronary artery or something like that. Sometimes we have patients that have a high bleeding risk, but that can be offset. In the case of thrombocytopenia, that's actually probably also a good point of interdisciplinary collaboration with hematology and oncology in terms of platelet transfusion thresholds and maybe bridging a patient with a platelet transfusion around the procedural period, if that remains a concern in the short term.
All right, I think we're at the 6 p.m. or 9 p.m. Eastern time cutoff. Thank you everyone again for joining. We had a great time preparing this presentation and hope that everyone learned a little bit throughout it as well.